I'm going to talk about syncope, evaluative modalities, and therapy. I'd like to give you an overview, the definition and background of syncope, initial workup, evaluative modalities, which include kind of all of these: ECG, carotid sinus massage, tilt testing, prolonged ECG monitoring, EP study, stress testing, and I'm not going to talk about ATP test because that's been kind of thrown out, and potential treatments for syncope. So first definition: syncope is defined as transient loss of consciousness due to cerebral hypoperfusion, and it's usually associated with inability to maintain postural tone. It has a rapid onset, short duration, and spontaneous recovery. And it's usually in the absence of any clinical features that are specific to another form of transient loss of consciousness, like epilepsy or some other condition. This is a nice algorithm that you can kind of follow. This is from the European Heart Association guidelines from 2009. Those guidelines have been updated in 2018, but I still think this is a very valid diagram. So the first question that you have to ask, and I think it's the hallmark of syncope, is whether or not the patient had loss of consciousness. Because patients are presented to you in the ER as somebody had syncope or near syncope. So the difference is near syncope means that you didn't really lose consciousness. You came near loss of consciousness, but you didn't actually have loss of consciousness. The hallmark of syncope is you actually had loss of consciousness and you do not recall anything. So the patient should say, yeah, there was a period there where it was just blank. I don't remember what happened. And then I just woke up and, people were around me trying to, help me recover. So if there is loss of consciousness, then you go down this algorithm. Was it transient? Was there rapid onset, short duration? Was there a spontaneous recovery? If the answer is no, so somebody has prolonged unconsciousness or had to be resuscitated, then we're talking about either a coma or aborted sudden cardiac death. If the answer is yes to all of these questions, then we're really truly are talking about transient loss of consciousness. And then the question is, was it traumatic or atraumatic? So traumatic would be, somebody hit you, you got hit by a baseball in the head and you lost consciousness. Okay, so that's basically a concussion. Or if you got, punched really hard, same thing. If it's a non-traumatic transient loss of consciousness, then, most often that's syncope. But it could be an epileptic seizure, it could be psychogenic, and there are other rare causes. One thing I want to point out is that when you hypoperfuse your brain initially, people tend to have some seizure-like activity. But the difference between syncope and an epileptic seizure is that the seizure is going to last for seconds to minutes. You're going to continue to see the patient seize for a while. With syncope or and I see this sometimes when pacing is inhibited on a pacemaker and you get sort of abrupt hypoperfusion of the brain, the patient will have some seizure-like activity for like maybe 5 seconds, like they'll shake their hands and then pass out. Okay, but an epileptic seizure should last longer than 5 or 10 seconds. Okay. In terms of issues regarding syncope, it is common, it is costly, it can be very disabling, right? So this poor guy here standing as a guard, he may not be able to do this job for too long if he keeps losing consciousness, right? So people can lose their job because of, recurrent abrupt syncope. It can cause physical injury. People often present in the emergency room with trauma. I took care of a patient about 6 or 7 years ago who was working on a scaffold doing construction work. It was a hot day. He experienced what we think was vasovagal syncope. He fell off the scaffold and broke his neck and became paralyzed. So that's an extreme outcome of something that's common and usually doesn't lead to as much injury, but sometimes if you have a bad fall, you can really injure yourself and, to the point that you could be paralyzed. Some people are very fearful that this can happen at any point, so they lose their independence. And there's some concern that if it's cardiac syncope, it can lead to sudden death. In terms of the breakdown etiologies for syncope, about 60% of syncope is neural-mediated vasovagal syncope. The most common term is vasovagal, but carotid sinus sensitivity falls under the same neural-mediated syncope. And there can be other similar triggers like cough or swallowing or post-micturition. All of these fall under neurally mediated syncope or reflex syncope. There are many names, but they essentially mean the same. And about 60% of the time, that's kind of the etiology of syncope. About 15% of the time you have orthostasis, so either drug-induced, somebody who's on multiple medications for blood pressure, volume depletion, somebody's dehydrated and all of a sudden they stand and they lose consciousness, or autonomic nervous system failure, either primary or secondary. We see this a lot in like Parkinson's disease and other conditions. And this constitutes about 15% of syncope. Cardiac arrhythmias, so bradycardia, whether sick sinus or AV block, or a tachy-mediated syncopal episode, a fast VT or SVT, or some other channelopathy, those all fall under cardiac arrhythmias, and they make up about 10%. And in terms of structural cardiovascular issues, a prior myocardial infarct leaving you with a significant scar or pump failure, severe aortic stenosis can cause syncope. You can have syncope in hypertrophic cardiomyopathy, in pulmonary embolism, in pulmonary hypertension, and obviously also in aortic dissection. These conditions make up about 5%. And then despite all that, we have about 10% of undetermined etiologies for syncope. In terms of the physiology of vasovagal syncope, the upright posture leads to pooling of blood. About 500 to 800 ml of blood can end up in the splanchnic circulation or in the pelvic circulation and lower extremities. And that leads to decreased return to the right atrium and ventricle, decreased cardiac output and blood pressure. That is sensed by the arterial and cardiopulmonary baroreceptors, which trigger a sympathetic activity, vasoconstriction, venoconstriction, and a rise in heart rate. That excess contractility is then sensed by C fibers in the ventricle, and a signal is sent to the brain. And sometimes you either have an ineffective reflex response, meaning you can vasoconstrict enough and you pass out, or you can have a paradoxical vasodilatation, which leads to further hypotension and ultimately loss of consciousness. And you can have either a pure vasodepressor response, which is purely hypotension. You can have purely a cardioinhibitory response, profound bradycardia or asystole, and most often it's a mixed response. And we're also dealing with reduced norepinephrine spillover to the plasma, and that can be in the form of either reduced norepinephrine synthesis or increased norepinephrine reuptake. This is a schematic of what we think happens. This is not clearly defined. I don't think you're going to be tested specifically on the mechanism or of at least in terms of when I studied for my internal medicine boards, cardiology boards, EP boards. I don't think there were very many questions specific on this topic, on this particular diagram. But I just want to mention this is the general sort of understanding that we have, and I don't think it's clearly defined, but we tend to have triggers, whether they're emotional triggers, somatic triggers, or some hemodynamic trigger that essentially go to the brain, and the brain either sends a signal back via efferent nerve fibers, and you can get vasodilatation of the splanchnic circulation or the lower extremities, or bradycardia and asystole, okay? Or you can have pure sort of autonomic dysfunction, like we do in Parkinson's disease, and those patients tend to have the inability to, chronotropic incompetence, the inability to bring up their heart rate, or they have inadequate vasoconstriction that leads to, higher incidence of syncope. They cannot react as fast to like these hemodynamic changes as a normal physiologic person. Okay, this is another diagram of basically what we talked about. If you look at the very top, it's a person leaning on a tilt table test. That's what we try to induce during a tilt table test, right? We try to cause this decreasing venous return by the upright posture, to leading to decreased left ventricular filling, increased sympathetic tone. But we're trying with the tilt table test to recreate what we think happens in normal circumstances and leads to, or abnormal circumstances that lead to syncope. This slide is from a study that was published in 2002. It's part of a Framingham study, and they looked at patients for nearly 17 years of follow-up. And the incidence of syncope is pretty equivalent between men and women. There is some variation depending on age, but I guess the greatest message of this slide is that as we progress through life, the incidence of syncope increases. And the overall, but in this study, out of 7,800 patients, 822 experienced syncope, at least one episode in 17 years. So that it was about 10.5% of the population they studied had syncope, and the incidence was 6.2 per 1,000 person years. Also from the same study, I find this slide to be very important. I think that if you deem that the syncope was purely vasovagal, that's the yellow line, well, that's a good prognostic indicator, because essentially it tracks patients who had no syncope, which is the black line. So basically, if it's vasovagal syncope, the prognosis is really good. You're not gonna die suddenly, you're gonna live just as long as people who had no syncope. However, if you find a cardiac etiology, that's the red line, then your prognosis is much poorer. And same if you find a neurologic cause for syncope. But as you can see here, the risk of death increased by 31% among all subjects with syncope. But again, when you break it down, vasovagal syncope has a benign prognosis, but the risk of death doubles with cardiac syncope. This slide shows the breakdown of causes of syncope by age. So in young folks less than 40 years of age, predominantly you have neurally mediated syncope. Less orthostasis, less arrhythmias. As you progress through life, in this 20 years between 40 and 60 years of age, orthostatic hypotension becomes more prominent, arrhythmias, and also all of a sudden you start building up cardiac structural heart disease. When you're over 60 years of age, you can see that, half of it is, a little more than half is neurally mediated syncope, and the rest of it has to do with either an arrhythmia, a structural heart problem, or worsening orthostatic hypotension. So the initial workup should include a detailed history and physical exam. That is a class 1 recommendation. I'm just going to go over it once. So class 1 means you should be doing it. Class 3 recommendation means you should not be doing it. You're doing harm. And then 2A and 2B, those mean 2A is based on randomized data, and most experts agree that you should be doing something, and class 2B is a softer indication, okay? For the most part, you should be practicing based on class 1 and class 2A recommendations. Sometimes I dip into class 2B recommendations, and obviously I try to never use a class 3 recommendation because that's contraindicated. So detailed history and physical exam is a class 1 recommendation. You should do that. You should do a 12-lead ECG on somebody who had syncope. Okay, that's based on the American guidelines. And the European guidelines from 2018 gave, tell us that we should also check for orthostatic blood pressure up front. The initial evaluation should answer 3 key questions. Was it a syncopal episode or not? Okay, the story that you get sometimes from the ER, you really have to go down there and interrogate the patient yourself. You need to ask them specific questions. Did you lose consciousness? Do you remember the entire event? Did somebody have to resuscitate you, or do you know if somebody, you have to talk to the patient. Has the etiology of the syncope been determined? Was there an ECG tracing showing ventricular tachycardia or fibrillation, or do we have, do we know what caused it? Is there evidence suggestive of high risk features for potentially future cardiovascular events or even death? What are the high risk features? So bifascicular block, okay, defined as either left or right bundle branch block combined with a left anterior or left posterior fascicular block, okay? So that tells you that there's some conduction abnormality there. So you may see right bundle branch block and you ignore it many times because the patient is asymptomatic, but for the patient who presents with syncope, even a right bundle branch block can be significant because that may be just an early sign of some infrahisian conduction abnormality that can lead to abrupt high-grade AV block and syncope. You should look at the QRS, okay? A narrow QRS, 90 milliseconds. You rarely have infrahisian disease when you have a very narrow QRS, but if the QRS is wide, irrespective of what type of bundle branch block you have, it's just a sign that, the electrical impulse is not getting down to the Purkinje fibers the way it's supposed to. It's not physiologic. You should obviously look for second degree AV block, whether it's Mobitz 1 or Mobitz 2. Mobitz 2 is definitely worse prognosis than Mobitz 1, but people can be symptomatic sometimes even with Mobitz 1 AV block. Are they having some baseline sinus bradycardia or even atrial fibrillation or atrial flutter with a very slow ventricular response? Because that might tell you that, okay, the patient right now has a heart rate of 40, they're asymptomatic, they're sitting comfortably smiling at me, but I don't know if the heart rate dips down in the 20s and they pass out, so some baseline sinus bradycardia or a slow ventricular response could be a sign of, even worsening bradycardia at times. If you're noticing episodes of non-sustained VT on telemetry, if you're seeing pre-excitation, if you're seeing a long or short QT interval, if you have early repolarization, if you have a Brugada pattern, those are the things you want to look for on the EKG and telemetry. If you have negative T waves in the precordial leads and potentially an epsilon wave, that can be suggestive of ARVC, another condition that can cause abrupt syncope, loss of consciousness. If you notice left ventricular hypertrophy on an ECG, that can suggest hypertrophic cardiomyopathy. So these things matter. The EKG matters. And totally normal EKG is a great prognosticator, right? Normal intervals, narrow QRS, none of these high-risk features, you're good for the most part. So this is what long QT might look like. This is what Brugada syndrome might look like. This is CPVT, you have bidirectional VT here, okay? Short QT interval or early repolarization are high-risk features. In terms of carotid sinus massage, so carotid sinus massage can be performed in patients more than 40 years of age. They say, to auscultate the carotids first, make sure you're not dealing with some bruit before you apply, and it's not really a massage, it's more like pressure on the carotid bulb. You hold the carotid bulb for about 10 to 20 seconds. Obviously make sure that there's perfusion from both carotids and no bruits before you do that. But if the patient has some abrupt pause or profound bradycardia associated with that maneuver, and we've seen people even pass out with carotid sinus massage, then that's a a prognosticator that, and sometimes we recommend pacemakers if the symptoms are severe. This is what a positive response might look like for carotid sinus massage. You get this abrupt, in this case, 7.3 second pause. An orthostatic challenge, so you can have measure the patient's blood pressure in the supine, the seated position, and the standing position. If you notice a drop in the blood pressure, the systolic blood pressure of greater than 20 millimeters of mercury, or diastolic drop more than 10 millimeters of mercury, and that happens within 3 minutes of standing, that's a positive orthostatic challenge. Or if you have a decrease in the blood pressure to less than, systolic blood pressure to less than 90. If you have that drop, irrespective of whether the patient passes out or not, I usually report it as, mild orthostatic intolerance or mild orthostatic hypotension, without symptoms. So, you can have orthostatic hypotension and the patient can be completely asymptomatic, or you can have, orthostatic hypotension and the patient loses consciousness. So depending on those findings is how I kind of tailor my report of a tilt test. Tilt testing has been around since 1986. It's a safe test. There have never been any reported deaths during tilt table testing. This is more or less what it looks like. Initially, we have the patient lay flat for about 10 minutes. Then we tilt them to 45 degrees for about 2 minutes. And then we go to 70 degrees. And the patient is strapped on their lower extremities, their torso. So it's a safe environment. If they were to pass out, they're not going to fall and hurt themselves. Usually the nurse is present throughout the duration of the tilt test. The physician often walks in and out, we keep checking on the patient to make sure that nothing abrupt happens. If the patient passes out, the table is lowered, they're given intravenous fluids, and they usually almost always recover. The endpoint of tilt table testing is induction of reflex hypotension and bradycardia. Sometimes you have a delayed orthostatic hypotension, and sometimes that's associated with syncope, and other times it's not. And again, the responses, I usually try to break it down. Was this purely cardioinhibitory? Did I see a long pause? Was it purely vasodepressor, or was it a mixed response? Indications for tilt testing. One is for the diagnosis of vasovagal syncope with a 2A recommendation. One is for delayed orthostatic hypotension, also 2A recommendation. To discriminate convulsive syncope from epilepsy, 2A recommendation for that. And for the diagnosis of pseudosyncope. So if somebody's on a tilt test and all of a sudden they just drop and there's no drop in their blood pressure, there's no change in their heart rate, it's probably psychogenic syncope. Okay, I've seen that twice, not that often. But tilt testing should be considered in patients with suspected reflex syncope, orthostatic hypotension, or POTS. Oh yeah, and in gold here, these were the American guidelines from 2017, and in white were the European guidelines. So they both give it a 2A recommendation. It's a bit controversial. Some doctors, they don't like tilt testing, but I do think that it gives us some useful information. But I guess my recommendation is don't stop at the tilt test, because sometimes you can miss more important and more bothersome conditions with worse prognosis. Limitations of tilt testing. A negative tilt test does not exclude the diagnosis of reflex syncope, and sometimes correlation of the type of response during tilt test and spontaneous syncope is questionable. So what I'm saying is that if somebody can have hypotension, even pass out during the test, but it doesn't necessarily mean that that's exactly what happens, and that exactly is what caused the spontaneous syncope at home. It just gives us some clues of what the patient may have. I recently had a patient who had a clear vasovagal syncope on a tilt test, but when I brought her in for electrophysiology studies, she also had Infrahisian Block. So if I had just stopped at the tilt-table test, I would have concluded that it's clearly vasovagal. I should stop here and give her midodrine and fluids, and but I would have completely missed Infrahis Block. The reason why I did an EP study on that patient is because she also had right bundle branch block on her ECG, which gave me a clue, plus her history. She was kind of standing, washing dishes, and all of a sudden she just had abrupt loss of consciousness. There was no prodrome. It wasn't hot. She wasn't standing for a long time. It just wasn't the classic presentation. So I decided to do a tilt and an EP study. The tilt was positive, but so was the EP study. So we ended up giving her a pacemaker. Cardiac monitoring. So we use a lot of these in electrophysiology for multiple reasons, but when somebody passes out, that's kind of one of our go-to systems to use. This is called the Zio patch. Many companies make them. We use Preventis. There's another company called Biotel, but they're very simple. We used to do halters with cables, and patient had to go home with a little box. But the past decade now, we've been using more and more of these. They're very convenient. They're very discreet. They're easy to apply. They go on the chest on the left side. As you can see here, there's a button in the middle. We tell patients to press the button when their symptoms are most severe, if they feel their heart racing, if they feel like they're extremely dizzy and about to lose consciousness. The importance is to have symptom rhythm correlation. That's the gold standard. So I want to know what the rhythm was at the time of the event, okay? So, and Zios are helpful because they help us accomplish that, have some sort of correlation that, when the patient pressed the button, they were in 2 to 1 AV block, or they had a profound pause, or nothing happened, and maybe it was blood pressure related, or they had chest pain. I don't know. Symptom rhythm correlation is very important, and this is one way to achieve that. Other modalities, telemetry, if the patient's in the hospital, you can give them a 24, 48-hour Holter. I almost never do this anymore. I've kind of either give them a Zio or go to something, so event monitors are Zio, Preventis, and like I said, Biotel, or we can go to an implantable loop recorder that stays under the skin for about 3 years. The duration of monitoring should be selected based on the risk and the predicted recurrence rate. So if the patient says, oh yeah, I pass out every day, so then you probably don't need a loop recorder, right? But if the patient says, I had an episode 2 years ago and I had an episode 6 months ago, you may not capture anything, in a 24-hour Holter or even a 2-week monitor. So if the patient says, the episodes are very infrequent, you might go straight to a loop recorder. So this is what they look like when you apply them on the chest. This is what a Holter kind of more or less looks like. In terms of the usefulness of external loop recorders, there's some, in terms of the diagnostic yield, there's some mixed reports, study from 1990 showed a diagnostic yield of 25%. This study showed a diagnostic yield of 63%. Other studies show that they're not useful. I think they're fairly useful if they're used appropriately. The implantable loop recorders. The old generation of loop recorders looked like this, about this size. We had to make a cut on the chest, dissect down to the pec muscle, and suture them on the pectoralis muscle and close the skin. The more recent loop recorders, the Link, and there are several other ones, are much smaller and they can be inserted without a significant surgical incision. It's a tiny little cut, and it's injected under the skin. These days, we do this in our office. You don't have to go to the hospital. It's kind of like going to the dentist. We give some local lidocaine with epinephrine, tiny little cut. It takes 5 minutes to put one of these in. One stitch under the skin and some surgical glue on the top of the skin, and that's it. The patient is set up with a home monitoring system that's at their bedside, and it communicates with a device. The battery lasts up to 3 to 4 years. The device is pre-programmed for significant bradycardias, less than 30 beats per minute, significant tachycardias. We set that as we please. And also the patient is provided with a clicker that they can put on their keychain. So if they have an episode, they can press the clicker and it basically takes a snapshot and it saves that snapshot of the event. Otherwise, the device continuously records things. So the looping means that you're continuously recording things and deleting, rhythm strips throughout the day, and it only saves those predetermined tachy, brady episodes or anything that the patient presses as an event. This study looked at whether or not you should wait to put a loop recorder in. And as you can see, the two pie graphs look just about the same, right? So whether you go straight to a loop recorder after the first episode of syncope or wait and have an extensive workup, echo, stress test, maybe a full neurologic exam, maybe a head CT, and if you don't find anything, then go to a loop recorder. There's not that much difference. The diagnostic yield, if you use a loop recorder early, is just a little bit lower than if you do the extensive workup, but they're very similar, 27% versus 35%. And the breakdown of what we find on loop recorders is also very similar. So about 50, so more than half the time you find some asystole or bradycardia. 8 to 10% of the time you find some tachycardia-mediated episode that causes syncope or near syncope. This is mainly syncope, true syncope here, or no arrhythmia in about a third of the patients. If you look at patients who had pre-syncope, the diagnostic yield there is a little bit lower. Okay, you get so with pre-syncope, you only get brady or tachy episodes about 19% of the time each, and the rest of the time you find nothing. So, ILRs are good for true syncope, less useful for pre-syncope. So here are the guidelines. ILR is indicated in an early phase of evaluation in patients with recurrent syncope of an uncertain origin. The absence of high-risk criteria, so you should look at the EKG and make sure you're not missing something, like long QT, and then just give them a loop recorder when they may benefit from a defibrillator, and a high likelihood of recurrence within the battery life of the device. And ILR is indicated in patients with high-risk criteria in whom a comprehensive evaluation did not demonstrate a cause of syncope. So as an example, let's say somebody has an ejection fraction of 40% and they had syncope, and you brought them in and you've done everything. They had a cath, they had an EP study, and you couldn't find anything. You should consider a loop recorder. That's a risky, it puts you in a difficult situation as a physician because, who knows if the next event that you might capture on a loop recorder might be a catastrophic event. But if you don't meet any criteria for pacemaker or defibrillator and your workup has been negative, this is what you're left with, unfortunately. And, the worst thing you want to see as an electrophysiologist is, you give somebody a loop recorder for syncope, and then they call you from the morgue to interrogate it, and you find ventricular fibrillation and death. Okay, that has happened, and it's very, very, very rare, infrequent, but it can happen. But again, if you don't meet any criteria for a defibrillator or a pacer, this is what you're left with. Electrophysiology study, the diagnostic efficacy of EP study depends on the pre-test probability. So if you have a hunch that there is, I'm seeing something here. I'm seeing left bundle branch block. I'm seeing, there's a prolonged PR interval here. There's some high-risk feature. There's hypertrophic cardiomyopathy here. Then the EP study is likely to be positive. But if you take a bunch of people with syncope and normal EKGs and you do a bunch of EP studies on them, then your diagnostic yield will be very, very low. So I don't recommend an EP study for everybody. I kind of, look at all the data, and if I see features that are suggestive of a conduction abnormality or an arrhythmia, then I recommend an EP study. And as you can see here, positive results occur predominantly in patients with structural heart disease. So if you know that somebody has had a heart attack, even if the ejection fraction is, 50%, if they have scar, you might find scar-mediated VTAC. So the EP study has a utility there. But in general, sensitivity and specificity are not that great. A lot of times EP studies are negative. So indications for EP study: if you have ischemic cardiomyopathy and you suspect an arrhythmic cause of syncope, just like I just said, a VTAC on a patient who has even a small area of scar and a preserved ejection fraction otherwise. Bicycular bundle branch block when non-invasive tests have failed to make the diagnosis. So you have a monitor, you give them an event monitor, they have left bundle branch block, you don't see anything during the event monitor, but the patient has passed out once or twice. You should do an EP study because there are clues during EP study that can tell you whether or not this patient is at risk for abrupt high-grade AV block. Syncope in patients with asymptomatic bradycardia. Okay, that's a softer indication, and syncope in patients preceded by a sudden and brief palpitation. So in asymptomatic bradycardia, what you're looking for a lot of times is, you're doing snerts to see if they have sinus node dysfunction. So if you can't prove it by an event monitor, you're trying to kind of assess it during an EP study. And syncope with palpitations, you're looking for an SVT mechanism there, or VTAC mechanism. So I was just alluding to sinus node recovery time, which is the test that we do for sinus node dysfunction during an EP study. And what we do is we overdrive pace the right atrium, and then you abruptly come off and you measure to see how long it takes for the sinus node to recover. So they found that in patients with sinus node recovery time of more than 800 milliseconds, so in electrophysiology we measure everything in milliseconds, they are 8 times more likely to have syncope than in patients with a normal snert below this value. If you suspect AV block in a patient with a bundle branch block and you have a prolonged HV interval, and I'll show you what an HV interval looks like. If the HV interval is more than 70 milliseconds, so the normal HV interval is 35 to 55 milliseconds. If it's more than 70 milliseconds, it's really bad. And if it's more than 100 milliseconds, it's really, really bad. Those patients are very likely to have abrupt, high-grade, or complete AV block and syncope and sometimes sudden death. Okay. We also use this procainamide infusion, 1 gram intravenous over 20 minutes. So if you have a marginal HV interval of 65, say, milliseconds, we give procainamide to see if we can push that out to over 100. And if it prolongs to over 100, that's also positive, and you should consider a pacemaker. Or if you see induction of infrahisian block, either spontaneously once you put catheters up or by pacing. In terms of suspected tachyarrhythmias, as I mentioned, we look for induction of SVT with associated hypotension. With patients with previous MI, you look for sustained monomorphic ventricular tachycardia. That's strongly predictive of syncope. All right. So now look at my last point here. Induction of VF is non-specific. Okay. You can induce VF even in normal subjects. But if somebody has had a heart attack and you either have a wall motion abnormality on an echo, or you have an area that there is no blood perfusion on a nuclear stress test or an MRI, and that patient loses consciousness, what you're trying to induce during EP study is sustained and monomorphic ventricular tachycardia, okay? That patient, even if the ejection fraction is 50%, should get an ICD, okay? This is what sinus node recovery time looks like. So just to orient you here, these are the surface leads. Here we're pacing in the high right atrium. This little ditzel here is the His signal in this patient, okay? So A, His V, A, you can't see the His V. You come off, this is your last pace beat, and you wait to see how long it takes before the return sinus bit comes in, okay? So that's sinus node recovery time. This is Infrahisian Block. Again, surface leads, P wave, QRS, T wave. This is what it looks like on the EP Pruka. We call it the Pruka. That was the engineer who designed the system that we use. But this is a signal from the high right atrium. And this is a catheter that's sitting across the tricuspid valve with the distal tip of the catheter in the ventricle, the middle part in the His, and kind of the proximal part in the atrium. So you get this nice signal of an A, a His, and a V, okay? Now look here. So you have an A, a His, and a V, an A, a His, and no V. So that means that you got through the AV node, you got to the bundle of His, and then you blocked. So we call that Infrahisian Block, and that has a worse prognosis than if you had A, no His, no V. That would mean blocking the AV node, and that's what you see with Mobitz type 1. That's more physiologic, meaning that most people have a Wenckebach periodicity. You block at some point. It's just a matter of when you block, and if the block is in the AV node or below. This case was somewhat controversial, in my opinion. It was a 45-year-old male, had mild depression. He presented with syncope. The story goes that he was caring for his horse. It was somewhere in Maryland. The horse accidentally stepped on his foot, broke his foot. Shortly after, and while he was trying to calm the horse and with his wife yelling at him, he collapsed. He fell on his face. He's an astute cardiologist in Maryland, saw that there was this ST elevation. It doesn't look like your typical, what I'm about to show you. But when we gave him procainamide, he had he had this, which looks very much like Brugada. So, he ended up getting an ICD. Okay, even though the controversial part here is that, this episode of syncope was probably vagal, right? I mean, his horse broke his foot and he lost consciousness. However, you also have this, and when you put the two together, syncope and Brugada pattern, anyhow, so this gentleman, it's a 2A indication, but if you look at the fine print down here, it says patients with syncope consistent with a reflex-mediated mechanism should not undergo the implantation of ICD. We brought this up with this patient. Sometimes you just have to have a discussion with the patient and say, well, we think you have this, but it doesn't necessarily add up. It could have been reflex-mediated. And if the patient says, I absolutely want it or I absolutely don't want it, sometimes you just have to kind of go with it. 50-year-old female with syncope, okay? What's the striking feature here, okay? She has a lot of LVH, right? And these deep T-wave inversions, right? So syncope on a person with left ventricular hypertrophy is a little more significant, right? Because if you do an echo and you truly diagnose this patient with significant hypertrophic cardiomyopathy and they had syncope, that's a high-risk feature, okay? And ICD implantation is reasonable in patients with hypertrophic cardiomyopathy presenting with more than one recent episode of syncope suspected to be of arrhythmic nature. A lot of times we just don't know. In terms of echocardiography, it is a class 1 recommendation for diagnosis and risk stratification in patients with suspected structural heart disease, 2-dimensional and Doppler echo during exercise in the standing or semi-supine position to detect provocable left ventricular outflow tract obstruction. So they're saying that if you have a patient with hypertrophic cardiomyopathy, sometimes you want to put them on a treadmill test to see if they obstruct further with peak exercise, so that's when or if the gradient, the left ventricular outflow tract gradient, the pressure gradient is less than 50. Also, you want to look for aortic stenosis, obstructive cardiac tumors, pericardial effusion and tamponade, aortic dissection, other etiologies. So echo is a very useful tool. It's benign, it's ultrasound waves. Exercise stress test should be offered to patients who experience syncope during or shortly after exertion. Okay, specifically there you're looking for catecholaminergic polymorphic VT. Though that's a condition where people describe as, I pass out when I peak exercise. It's really bad, right? I mean, anytime somebody passes out at peak exercise, not during the recovery period, but at peak exercise, that's bad. You want to assess for long QT and if they can shorten their QT with exercise. If you have a type 1 Brugada ST elevation during exercise or in recovery, or if you develop abrupt heart block, 2nd or 3rd degree, that gets worse with exercise. In terms of the diagnostic yield of all these modalities that we just discussed, in this study, they found that tilt testing gave us a diagnostic yield of 58%, and then everything else, EP study, carotid sinus massage were lower. So unfortunately, you have to use multiple of these to get somewhere, because often, the individual tests have a low diagnostic yield. So if you diagnose somebody with vasovagal syncope, you educate them, you tell them that their prognosis is fairly good. We recommend counter pressure maneuvers, so teach the patient to brace down. If they feel a prodrome, sit down to prevent trauma, brace, and it usually resolves. Increase salt and food intake. Sometimes I recommend low carb Gatorade. As you know, the Gatorade was developed in Florida for the University of Florida Gators in the 1960s, I think, and it was basically water with electrolytes. And what they found was that water with electrolytes rehydrates you better than just water alone. So you need salt and water to rehydrate appropriately. And what they found was that less athletes were passing out, and they ended up winning the national championship that year, and everybody thought that Gatorade was the magic drink. And anyhow, that's the story about Gatorade. And if you look at all the medicines that we can potentially use for vasovagal syncope, the only one that has a class 2A recommendation is midodrine, and everything else has a softer recommendation. So fludrocortisone, beta blockers, orthostatic training, all this stuff, selective SSRIs or a pacemaker, they're kind of soft indications. If you suspect syncope due to orthostatic hypotension, which we previously defined it, if it's due to dehydration, rehydrate. If it's due to drugs, reduce or withdraw some of the medications. If we think it's neurogenic orthostatic hypotension, give them water, and then you can use some of these recommendations: compression garments, counter pressure maneuvers, midodrine, droxidopa. This is a recent medication that came out in the market. It's called Northera. Sometimes it works, sometimes it's ineffective after so many years of usage. If you're gonna give somebody a pacemaker, and I'll go into more details, the pacemaker of choice is something with a is a dual chamber device with closed loop stimulation, which is a very specific algorithm. It senses a drop in the impedance right before syncope is about to happen, and it actually kicks in and paces a little bit faster in order to prevent the event. And this is a small study of about 50 patients, somewhere in the control arm, somewhere in the CLS arm. And what they found was that with the CLS algorithm, the patients had significant reduction in the vasovagal syncope, and they followed them up to about a year. So this was published in Europace in 2004. Then there was the Spain study that was published in 2017. They also, I guess, retested the CLS algorithm. This time everybody got a pacemaker. DDI is a non-tracking mode. You know, you're basically turning off the pacemaker with DDI, and DDD-CLS was the algorithm. If you look on the slide on the left, this is the proportion of patients with syncope, okay? With DDD, so this slide shows that this group had the pacemaker on DDD-CLS for 12 months, and then they flipped to DDI, and this group in red was DDI for the first 12 months, and then DDD-CLS for the remaining, okay? And then you can see here that there were no events, and then as soon as you turned off the pacemaker from CLS to off, you had increased incidence of syncope. The other group had syncope, and then once you turn CLS on, no more syncope. The curve flattened. And then here, the slide to the right just shows patients who were all along over a period of 12 months on DDD-CLS, and versus, you know, you can see that there was basically no symptoms, no recurrence of syncope. The Issue 3 study was published in 2012. Again, they took patients that had a syncopal episode, spontaneous, associated with asystole of greater than 3 seconds, or a non-syncopal asystole of more than 6 seconds. And they were randomized to either have pacemaker on, they all got a pacemaker, then were randomized to either a pacemaker on or off. And what they found is that the pacemaker helped. There was a 32% absolute risk reduction and a 57% relative risk reduction in syncope at 2 years. But what, as you can see here, even patients who had the pacemaker on continue to have some episodes of syncope. So this was a paradox. So they said, well, why would somebody with a pacemaker still have syncope? And then they took this subset of patients and they gave them a tilt test. And what they found is that the patients who had the patients who had a positive tilt were the ones who continued to syncopize. So that was probably a blood pressure related issue. But, you know, the patients had a negative tilt table test with the pacemaker, did really, really well. And that made it basically to the national guidelines. And basically, you know, dual chamber pacing can be effective for patients 40 years of age or older with recurrent and unpredictable syncope who have documented pause of more than 3 seconds during syncope, or an asymptomatic pause of more than 6 seconds. So this recommendation comes from the Issue 3 study. Tilt table testing can be considered to identify patients with a hypotensive response who would be less likely to respond to permanent pacing. Okay, that's also from the subset of the Issue 3 study. Okay. You know, you're not going to put a pacemaker for unexplained syncope or unexplained falls. We need some data. Okay, otherwise it's a Class 3 recommendation. And then this was a study published in 2016 at the New England Journal of Medicine, and it showed that pulmonary embolism was identified in nearly 1 of every 6 patients who were hospitalized for a first episode of syncope. So think of PEs also. These are the recommendations: education, reassurance, promoting salt and fluid intake, Class 1, reducing backing off on some medications, using physical counterpressor maneuvers, use of fludrocortisone, beta blockers, midodrine. The midodrine has a higher, this is an older data. The midodrine has moved up. In terms of, this is a slide from the most recent 2018 guidelines, the European Heart Journal. And I just want to point out some things that have shifted from class 1 to 2A or vice versa. If it's a busy slide, so you may want to have to review this on your own. Conclusions, 12-lead ECG is mandatory in all patients with syncope. Continuous ECG recording is the gold standard to establish symptom-rhythm correlation. ILR should be considered early in the workup of unexplained syncope. Class 1 drug challenge should be performed if you suspect a Brugada. EPS is most useful and sensitive in patients with previous MI and patients with some form of bundle branch block or wide QRS. Based on the composite of available data, there seems to be a role for permanent pacing in selected patients with neural-mediated syncope. Patients with a negative tilt table test may benefit most from pacing.